It's
Sorry about that.
oh, little technical glitch there. No worries. Welcome back, everybody. I hope everybody did get to stretch a little bit and maybe get a quick bite to eat. I know it's kind of like eating in record time during these breaks, but it's my pleasure to introduce our next guest. Laura Daniel has a BIS with a focus on psychology, education, and nonprofit management. She has served as a medic in the military and she has 10 years experience in the healthcare field. She's been with Rappahannock Rapidan Community Services, RRCS, one of our very close partners with Aging Together, by the way, since the implementation of the Care Transitions program back in 2017. Um, Ms. Daniel works as a health coach with the Care Transitions Program and care coordinator with other projects at RRCS. I am really excited to hear about the Care Transitions Program, to learn more about it myself, and also to hear a little bit about the Healthy Ideas Program, which we'll be implementing in our region. I think we're in the process of implementing, but I think we're going to hear more about that from Laura. So over to you, Laura.
Okay, thank you so much. It's a pleasure to be here with everyone. So thank you as I walk you through this. So bear with me while I share my screen. All right. Okay, so I'm here to introduce the Care Transition Program and the Healthy Ideas Program. So I'm first going to talk about the Care Transition Program. Basically, I'm a health coach that's part of this program. And as you can see from this slide, you can kind of see that there's a whole big circle, just kind of this whole big transition from that people make from the hospital to home. Sometimes they do a step off at like a skilled nursing facility. You got to incorporate the primary care doctors and other specialties that are involved, that kind of thing. But a key takeaway from this slide that you should take is pay attention to the middle. The middle is the focus of patients, their family members, their caregivers. All of that is truly the heart of the transition. So the Care Transition Program is an evidence-based model designed by Dr. Eric Coleman to empower individuals, their families, and their caregivers to actively participate in their healthcare needs to reduce hospital readmissions. So basically, what does that really mean? So a care transition coach, or also known as a health coach, works to transfer skills that allows an individual or their caregivers or family members to recognize what we call red flags, communicate effectively with their medical providers, identify medication errors or medication discrepancies, and to keep track of important medical information, all with the ultimate goal of significantly reducing that hospital readmission within the first 30 days. So basically, this program consists of a hospital visit, a home visit. Now, if a member discharges to the skilled nursing facility, like I mentioned, then we'll do a quick visit there just to kind of touch base in the process. And then when they get home, we'll do that home visit once they get home. And then it consists of 3 follow-up phone calls, just one call once a week after that. Making sure that the members are still doing okay, that they still have everything that they need, following up on key points that were hit on with the home visit, that kind of thing. And all 3 steps are all with the focus of Dr. Coleman's 4 pillars. So what are the 4 pillars? So Dr. Coleman identified when he did his research, because this is evidence-based, he identified 4 key areas that we need to pay attention to. So medication self-management. Does the patient, are they knowledgeable about their medications? Do they have a system in place? All of that with the focus to reduce those medication errors. And then the patient-centered record, also known as a PHR, personal health record. It's a little colorful booklet. We make it colorful so it stands out. This is a way for them to track their medical information and help improve that communication with the primary care doctor or specialist, even the pharmacist, that kind of thing. Follow-ups, making sure that they scheduled a follow-up, that there is a follow-up scheduled, that they completed that follow-up, and just making sure that that's, taken care of. And then we also pay attention to the red flags. So these are the things to indicate to the people, are they, what they need to look for if things are getting worse, and what they need to do, because that's important too. How do I manage this? So like I said, there's 3 steps. The first step is that hospital visit. So we get a referral that says, hey, look, this is the patient that you're going to get. So once we get that, we make contact. Now, granted, remember, everything's a little bit different because of COVID, and I'll go over that in a little bit on how we've kind of adjusted with that. But if it's in our local area, we'll go into the hospital, we'll introduce ourselves, we'll confirm their contact information, we'll kind of give them a preview of what to expect. We also address any concerns that they have, things that they need to look for before they're leaving, making sure that, that communication is open too on, hey, when they leave, they're going to need a wheelchair, or they're going to need crutches, or they're going to, various different equipments that they may need at home. So we do that brief assessment. We kind of get a starting point of where we're going to go. And like I said, that visit is conducted within the first 24 to 48 hours of receiving a referral. It also depends on too, if over the weekends, holidays, that kind of thing. Each program is a little bit different on, do we work the weekends? Do we work a holiday? Does it not? So it may not pick up. It may go beyond that 48 hours. So like I said, if a patient discharges to a SNF, because sometimes that needs to happen, they just need to do a rehab. So we've touched base with them in the hospital. We'll go and visit them over at the skilled nursing facility, again, to, make sure that that transition from one to the other went smoothly. We work with the discharge planner. We, again, make sure that those needs are, met or put in place for them to, because maybe they knew, the hospital knew, but maybe the skilled nursing facility does not know what they're doing or what they may need when they get home. So we just want to make sure that everyone's on the same page, just kind of assist with that. And then we continue to monitor them until they get home. So once they get home, our goal, our ideal thing is to touch base with them within 72 hours of discharge. So the first 3 days, that way we can get in there, we can assess their needs, we can address any, anything that may come up, any ongoing things, that way that they are set and can move forward. We utilize that PHR, the personal health record, that little colorful booklet for them. We address the 4 pillars, going over their medications, the red flags, what they're going to do if they notice things, their follow-up appointments. Do they need help scheduling it? Do they have the appointment? Does the appointment time that they may have been given, does it work with their schedule? Do they have transportation? That kind of thing. And then we also connect them with any community resources we may identify that they may need during that time. So the nice thing about going into the home too, we can pay attention. We're trained, we pay attention to the fact of, are there things that they need at home? Is food insecurity a thing? Are, different things? Do they not have a safe way to get in and out of their house if it's a wheelchair bound person and they may not necessarily have a ramp? So we can certainly, we take all of that into consideration, and we use that to really address those needs with those individuals. And after that initial home visit, we do 3 follow-up calls, just 1 call once a week, just touching base with them. We're reinforcing the education that we gave. Do they have, if medication was an issue and they didn't have a system in place, do they now have a system in place? Do they have a pill box? Do they have reminders set in place? Do they understand their medications? Were they able to get their medications from the pharmacy? Just addressing certain things like that. Again, following up on any issues we noticed or any needs that they saw. And we really act as an extra advocate during that time for them too. And then, like I said, this whole process kind of spans over 30 days, but sometimes people need a little bit more, so it may involve some additional calls. Sometimes, if need be, we can actually visit them more. It really, it's just on what the individual needs or what the caregivers need, and ensuring that those needs are met. And really, it's just to ensure that safe transition from the hospital to home. So, really, why is this important? So again, these numbers are pre-COVID. You gotta realize that COVID has changed everything. But DARS identified that 1 in 5 Medicare patients discharged from the hospital, or roughly 2.6 million beneficiaries, readmitted within 30 days. With a cost of over 26 billion a year. And that's not even addressing, private health insurance and stuff like that, that have also seen the cost of readmission. And even hospitals themselves, hospitals have put this program into place. We work with hospitals to conduct this program for them so that they can reduce those fines, because they get fined if these individuals are readmitted within 30 days. So, hospitals realize that they needed to step up and do what they can too to ensure the transition is really met. um, and how they kind of got to this point. Dr. Coleman and hospitals did a root cause analysis. They identified specific areas in this root cause analysis. And what they found was medication mismanagement, no follow ups, and non compliance were some big issues. Patients were also saying that they couldn't afford medications, they didn't have a transportation to their appointments, they were confused about directions, various things like that. They may not have known what to look for, what to do if things got, bad like that. So the research, like I said, this is evidence-based. They found after Dr. Coleman completed his all of his research, readmissions reduced by 20%. They saw an improvement in the quality of life and healthcare for patients. And it's not just a medical need, they also saw a difference in the community and partners. And based out of this research, Dr. Coleman created the Coleman Care Transition Program. And all of this is patient centered, which is key to remember with anything. When you're giving any type of care, it's important to remember, the patient is the heart and center of it all. And why it's beneficial. I know in the state of Virginia, the BAAA Cares has partnered, and they kind of oversee all of the AAAs in the state of Virginia that conducts this program. And they realize, we have these key components, there's red flags, the medication reconciliation, the PCP follow-ups, that kind of thing, that the program focuses on. Then they also, as a AAA, can incorporate different programs too. Am I identifying an individual that would benefit from the chronic disease self-management or fall prevention program? The healthy ideas, all of this, different programs that we run that we're able to incorporate to ensure that these individuals are getting their needs met. And it kind of goes along with the other other services. Transportations, if a client can't get to his follow-up appointments to follow up, we can address those transportation needs. We can put them in touch with our local resources. If an individual is not eating healthy and doesn't consistently have meals and can't afford meals, we can refer them to the Meals on Wheels, the home delivered meals program. Same thing for the VICAP counseling or the personal care aid. I mean, these are all different programs that the AAAs, and in our case, Rappahannock Rapidan Community Services, because ours is combined, has these programs so we can put them in touch. It's a nice, incorporated way to run the program, and because we know these programs, because we can refer, it really just overall addresses all of those needs that the individual has. We can work with the primary care doctor. We can work, with the transportation services or the Meals on Wheels. And you're just kind of addressing the whole picture of the individual and ensuring those needs are met, and once the needs are met, then, you're completing the process. You're breaking the cycle. Um, So that's kind of the care transition program. I will take a minute before I run into the Healthy Ideas program. It's like I said, everything has kind of changed a little bit because of COVID. When things were really, on lockdown, we weren't allowed to go into hospitals, and still it depends on each hospital is a little bit different on if we can go in. And it also depends too on what the individual is admitted for. That plays a key part too. Um, so a lot of what we've had to do is move to telephonic, and then it's kind of like a hybrid model. I know some in our area, some people just don't want us coming into their homes right now. So we kind of leave it up to the individual. Eventually things may get back to where we can all safely meet. But what we can't do in person, we're doing telephonically. And I know that itself brings its own challenges. It means I can't go into the home and identify as many needs as I may have, if I was actually in the home. But then you're having to rely on other stuff, what's going on in the background, their tone of voice, that kind of things. So again, we're doing like everyone else. You're adjusting to the best that you can. I will say I guess like everything else in the healthcare, our numbers have increased just because there's so much of a greater need for it. So the second program that I'm here to discuss is the Healthy Ideas program. And this is not in place yet. I know our RCS is trying, along with Ellen and a couple other individuals in the community, to get this program into place. So it's not actively started yet. But the Healthy Ideas program stands for Identifying Depression and Empowering Activities for Seniors. So this program is specifically geared towards seniors, whereas the care transition program is all ages. So this program is also an evidence-based program that basically incorporates depression awareness and management into existing care management services. It ensures older adults get the help that they need by identifying those symptoms and managing those symptoms and figuring out how to live their life fully. I mean, if you understand it and you understand how it relates to yourself, and then you're giving coping mechanisms, you can then deal with it and learn how, okay, this is how my life, this is what I have to do to manage it. And they can, it improves life greatly. The Healthy Ideas program improves the life by these key areas. They screen for symptoms of depression. There's several assessments that they can use, and it also assesses the severity of it. So you kind of have a big picture of, okay, what are we dealing with? And then it works on educating older adults and caregivers about the depression, and then it links them with primary care doctors and mental health specialists that can address those. Maybe this individual needs counseling, or maybe this individual needs medication management and their primary care doctor doesn't feel comfortable. So identifying that and linking them to the appropriate resources. And then it also empowers individuals to manage their depressive symptoms. So there's different coaching mechanisms that are taught, and kind of those coping mechanisms and different skills that can be relayed to individuals to kind of help identify and manage that. And then along the way, you're going to assess the client's progress and just kind of, it's a whole give and take kind of thing. You keep working on it. So those core components, like I said, I've kind of went over just previously. So it's basically those 5 steps are what they call the core components. The Healthy Ideas program is a little bit different. So this is a much longer period instead of 30 days. The Healthy Ideas is conducted over 3 to 6 months. and it consists of 3 face-to-face visits along with the 3 telephonic visits. So it's a much more in-depth, longer relationship to kind of make sure that all the needs are being addressed. Again, why is this important to people? You know, they have found for seniors that participated in the program, there were fewer symptoms of depression. They noted decreased physical pain, better recognition and self treatment of symptoms, just an improved well being. For the providers that provided the program, the capacity to address depression, better communication, and stronger partnerships among healthcare providers and all providers, the opportunity to deliver a successful program, and just improved staff knowledge and confidence. The CSBs or the behavioral health boards and partners, they noticed an increased opportunity to work with diverse populations. They strengthen those connections with different community agencies and a greater opportunity to serve an underserved population of individuals. So that's where I leave you guys to. I'm going to open it up for questions because I know I've thrown a lot of information. Before I open it up to questions, I do want to say thank you for listening to me. I'm going to go ahead and stop sharing my screen and let's see if we have any questions.
Thank you, Laura. That was, like you said, it was a lot of information. I'm going to kick off with a question. I might have missed this, but
Okay.
going back to the care transitions,
Okay.
what would happen? Let's say, for example, you do an assessment and someone's going from the hospital back home, and what if you were to find with your assessment that there's really not sufficient support at home, and it's maybe a concern. Um, and I know there are programs to connect the person too, but what if they didn't have the sufficient support? How would you all handle something like that?
Great question. So it really just depends. I mean, of course, we're mandatory reporters. So if there is something that, we are certainly concerned that we have to report it, we're going to report it certainly. If it's something that this individual could benefit from additional supports, and they just don't have it. They don't have any local family. They don't have any, they haven't made any community connections. So they don't have a church that they've connected to. So they don't have that church support or anything like that. They don't talk to their neighbors, or they're rural, like most of us here. They may not have a neighbor that within a mile of them. So, if it's something that they are struggling with their daily activities, getting dressed, fixing food for themselves, that kind of thing, we can certainly do the referral to social services to get the UAI completed so that we can see if they qualify for a personal care aid, that kind of thing. Also, would it benefit from them to, do they qualify for Medicaid? Is that a benefit for them? That kind of thing, depending on insurance wise. If, say, they don't qualify for Medicaid, and the UA is completed and they need help, but because they don't qualify for Medicaid, there's really no community funding, state funding for it. So it then becomes the thing of, do they pay on their own? Are there any community groups that we know that we can put them in touch with? That kind of thing. So it really just depends on the individual and the needs on how we go about tackling it, that kind of thing. Does
That's
that kind of
great.
answer your
Oh,
question?
absolutely. Yeah, that's really good. Really appreciate all the work that you and your team do. It's such an important service. That really was a lot of great information. We have a question, um, actually to everyone, but maybe this is something that you might also be able to help with. How can you assist with respite care? Well, that's a great question, but maybe some of the same, some of those resources that you were just talking about? I don't know.
So again, I mean, there are some services that we know, that offer respite care. So we make sure that you know, if it if the patient themselves, cannot really interact, and we're really doing that education and working with the caregiver, and we can tell, one of the things that we address too is caregiver burnout. So we make sure, are they aware of, the caregiver burnout, that it's a real thing, and are they participating in support groups? Are there, different grants that they can access, that kind of thing. And so we kind of work with that. In regards to working with the respite care providers themselves, we really haven't built that relationship. It's really kind of hard. Again, if that caregiver needs help relaying the education or certain key points, we'll certainly work with those providers when when it's needed, but we haven't built a relationship specifically on that. But in regards to respite care, it's really one of those things that you have to focus on too when you're doing that home visit, and or you're even on the phone and you're working with those caregivers, that they recognize, how are they doing too? That's one of the questions I always ask. How are you doing? Yes, I'm here for the patient, but I also want to know how you're doing, because you're the primary caregiver. And if you are struggling, if you can't take care of yourself, then how are you going to be able to take care of that individual? So does that answer your question?
Um,
Okay.
yes, Ursula said yes, thank you. And I know um, Ursula is with Cornerstone Cares, and I believe they have some funding still for respite care. Ursula, I hope I'm speaking correctly and not talking out of turn, but they certainly do provide a lot of support for caregivers as well there. So um, yes,
Excellent.
she said yes. Okay. um,
Excellent.
any other questions for Laura? I am excited that the Healthy Ideas program is going to be starting. I think that screening, having additional supports for screening for anxiety and depression, especially in these challenging times, is going to be really an important service that you all are going to be providing,
With
along with
it.
everything else that you do.
Yeah, just add it to the list. It's fine. And I think these times, if anything, has shown people not only how resilient they are, but also how human they are, and how we need to pay attention to these connections and to our own self, and recognizing that you may have been able to manage just fine, but with everything, you're suddenly realizing that the coping mechanisms that you have are just not cutting it. The the support network that you had been disconnected, because of isolation. And this program can really work with those individuals to say, hey, it's okay. These, this is where you're at. These are some coping mechanisms. These are some providers we can put you in touch with, and we can work with you to really, bring you back to a point where you can manage. So hopefully, that kicks
Absolutely.
off soon, and that'll help. So
Absolutely. I'm looking to see if there are any other questions in the chat. Um, don't see anything at this
Yes,
point.
looks like we got through everything, and we are I like how somebody said here, sounds like it will help bring some normalcy to daily living. I agree. Yeah. So okay, so Ellen, we are ahead of schedule here.
Yes.
So we can do a couple of things. We
Let
can
me,
take,
yes. Yeah, let me first I'm sorry, Steve, to interrupt. I know this is one of the challenges of the Zoom. I do want to again just thank you, Laura, so much. That was really, really, really excellent. and a lot of really good information. So I appreciate that so much. I'm sorry. So
Thank you.
Steve, yes, we're ahead of schedule. We have a raffle yet to do. And what do you think? I mean,
Oh,
I'm a,
well, let's,
yeah.
yeah, let's let Laura, while she's on the screen, she can do the honors and spin the virtual wheel to see who our next
Woohoo!
winner is. So
Okay.
Laura, if you just raise your hand and give us a virtual spin. There we go.
Yay.
That always
Awesome.
uh and our winner is Judith Honesty.
Judith
Yay!
Or
Honesty.
Honesty.
Woohoo!
Yeah.
Okay.
So I'm not sure
Great.
if Judith is in the audience. Our last winner was, and that was really exciting. And
Yes,
that's
and if
that.
Judith, I think somebody Ginny will private message you, Judith, if you're on, and try and get your address. But I
If
think we have
not,
your email address anyway.
yeah, we can email her.
Yes,
Um,
perfect.
so okay, so let's see. Um, we have the option of going straight into our next session with Poppy, or maybe because she's here, um, or what I'm thinking is, why don't we do like a 10-minute break till 12:30, and then we'll start with Poppy, and then we'll make sure we reach out to Amy and see if we can't get her available so that we can sort of push the whole agenda up. Does that sound okay?
Yes, and of course, anybody who jumped off and then came back on, everything's going to be recorded, so
Yeah, so that'll
they
be a
will
good.
still get the chance to hear that. But I do have a question